Hello, my name is Alistair Kiriki. Today I'll be demonstrating the difficult airway drill and failed intubation drill, ultimately resulting in the front of neck access in the can't intubate scenario using the Quick Track 2. The location of the cricothyroid membrane is located between the thyroid cartilages and the cricoid cartilages. In men, this is the prominent protuberance, which is known as the Adam's apple. In women and children, the differences between the cricoid and the thyroid cartilages can be difficult to distinguish. The cricoid thyroid membrane is found approximately 1/3 of the distance between the manubrium and the chin in the midline in the anatomically normal patients. In order to locate my cricoid membrane and my target site of insertion, I first must palpate the trachea. I start at the sternal notch and work upwards, palpating as I go, noting the bumps along the way. There's a solid protuberance, which is the thyroid cartilage. When my fingers fall off, in theory, that is the edge of the thyroid cartilage. I then palpate backwards towards the feet, noting the first soft spot after the thyroid cartilage. This here is the cricoid membrane and my target site of insertion. The vascular structures potentially injured during correct insertion of the Quick Track 2 is the thyroid artery and vein. The artery, a branch of the aorta, runs up the midline towards the thyroid gland. The vein crosses the midline at the same level. These arteries and veins infrequently reach the level of the cricothyroid membrane, resulting in rare severing if insertion is undertaken. Even more rare is that of poor technique or incorrect landmark identification. This can result in carotid vessels being severed, resulting in catastrophic outcomes for the patient. Acute complications after emergency cricothyroidotomy occur in up to 15% of cases. Most commonly, venous bleeding, which is self-limiting. More infrequently, arterial bleeding may require hemostatic dressings to cease the hemorrhage. In obese patients, it is possible to place the tube or device too anterior to the larynx and trachea and into the mediastinum, making ventilation impossible. Alright, we have a patient with good oxygenation, pre-oxygenated for 5 minutes, with oxygenation of 99%. If we can administer the medication, please. We have apnea, loss of jaw tone. I'm going to go in with my first attempt of a steel blade. Scissoring open the mouth, in from the right, sweeping the tongue past the teeth. I have a lot of vomit in the oropharynx. I will suction that as required. I can see hard and soft palate and uvula, but I cannot see epiglottis at all, or cartilages. I will come out. I will reposition my patient to try and optimise second pass attempt using the video guided laryngoscope. I will also attempt to add some external laryngeal manipulation this time. Going for my second attempt, patient's oxygenation is still above 93%, so we don't need BVM. In past the teeth, down past the tongue, soft and hard palate seen, uvula noted. Cannot see epiglottis, still cannot see epiglottis, but I can note a large tumour and what looks to be a large abscess there, which I believe will make SGA insertion impossible and intubation is impossible at this point in time. I will come out. My oxygenation is dropping down to 90%, so I will return to bag valve mask at this point in time to see if we can oxygenate but not intubate. I cannot achieve oxygenation with a one-handed seal. I will try a two-handed seal and attempt someone else to squeeze the bag to see if that improves my oxygenation saturations. It is not. We are now below 90%. We're now in a can't intubate, can't oxygenate scenario. We're in a failed airway. I will now insert a surgical airway by the front of the neck in the cricothyroid membrane that has been marked. Marking up my patient again while someone continues to bag valve mask. Marching my fingers up, feeling the thyroid cartilage. When they fall off, mark back to the soft point, mark this is my access point, and I will demonstrate how to insert the Quick Track 2. I will now demonstrate the Quick Track 2 for emergency cricothyroidotomy. As always, locate your target site by palpating up from the manubrium to the thyroid cartilage. When your fingers fall off, Pull our back down to the soft marker. This is our target insertion site. Put a mark. Ensuring our gloves, goggles and our PPE are on. Open our kit. Now this is a training kit for our micro branch that we work at. What you would get in this kit would be two 10mm syringes, the Quick Track kit itself, a scalpel, a foam neck holder for the device, and the attachment for your BVM. Unfortunately, we don't have the attachment for the BVM or the foam neck attachment. Fill up one of your 10mm syringes with approximately 3 ml of saline. Attach the one with the saline to the green stopper of the Quick Track kit. Stabilise your neck and the trachea with the non-dominant hand. With your dominant hand, make a 1 centimetre vertical incision, approximately 2 to 3 millimetres deep, not to puncture the membrane, but enough to ensure that we get through the soft tissues above the membrane. Dispose of your shaft in a shafts container. Using your Quick Track 2 kit, make it at a 90-degree angle, insert down to puncture through the membrane. Once we puncture through, reduce to 60 degrees and aspirate air. If we aspirate air, we can advance to the red stopper, remove the red stopper, advance further, aspirate air, pull back on the green attachment to ensure an audible click, to ensure the sharp is away, which has happened there. From here, advance the whole device further down the neck to ensure flush. Remove the sharp, dispose into a sharps container. With your second 10mm syringe, inflate your cuff. Attach to the connector that would come with the kit to a bag valve mask, 6 to 7 mils per kilo. A couple of breaths to ensure end tidal placement. Now, if we do not get end tidal waveform, again we have to remove and reassess. Once we have end tidal waveform, connect the foam attachments around the neck. Ensure sedation and paralysis are ongoing as per any intubation that Ambulance Victoria undertake. And from there, we have to transport to hospital. Now, this is where it gets difficult. We cannot currently, Road Mica have the Medumat 2, which is unable to be attached to the Quick Track 2. So we have to hand ventilate using a bag valve mask to our receiving hospital with notification. This is how you insert a Quick Track 2 in the emergency setting of cricothyroidotomy.